Good afternoon to our colleagues from UIC. I can see Dr. McIntosh is logged in. Hi.
Hello, yes, we are here. Thank you for the invitation. Dr. Chan will be joining us shortly. We're just getting our computer set up.
Perfect.
But I think your team is going first.
Oh, correct.
Is that right? Okay.
Oh, correct.
Great.
Thank you. So let's begin with our first case. It's Dr. Daniela Larrubia. You can begin your presentation.
Okay, good evening. My name is Daniela. I'm a second-year resident in the service, and I'll be presenting the case from the oncology department. My preceptor is Dr. Luis Fernando, and I would like to thank Dr. Norma Aleman and Dr. Carla Macedo for the help with the case. The case involves a 3-year-old boy, and the father reported a red eye and photophobia in the right eye over the last week. He also noticed a white reflex in the right eye over the last 3 months and denied any trauma. There were no history of ocular diseases in the family, and there was no significant ophthalmological or medical history. On the ophthalmological exam, the patient had no light perception in the right eye and could fix and follow with the left eye. I'll show photos of the right eye, and in the left he had clear conjunctiva, transparent cornea, and was phakic. The intraocular pressure was 32 in the right eye and 16 in the left. The fundus exam was impossible on the right eye, and I'll show photos of the left. This image is a RETCAM photo.
Good evening, everyone. My name is Gustavo Mejara. I'm a first-year resident here at the service at Escola de Medicina. So it's difficult to assess some characteristics in the slit lamp examination of the right eye, but we can see that the pupil appears to be dilated, and there is some yellowish material in the anterior chamber, and the cornea appears to be clear, but it's difficult to say more details due to the further opacity.
Okay, during the examination, we could also see that the patient had blood in the anterior chamber. He had dilated vessels in the conjunctiva and episclera, a corneal edema, and it was difficult to see more details, but we could not see the lens in this patient. The fundus of the left eye.
So here we can see a pink optic disc with sharp margins, normal vessels, normal macula, and the retina is attached.
Perfect. So, from the diagnostic hypothesis, the patient appeared to have hyphema in the anterior chamber disorganization. He also had elevated intraocular pressure, probably a dislocated lens, and we also suspect of a vitreous hemorrhages. The main cause in childhood with this appearance, we would think about trauma. However, the patient's father denied any. Other possible causes include coagulopathies and ocular tumors. For the management, we request an ocular ultrasound and cranial and orbitis imagings. On the ocular ultrasound of the right eye, in the axial scan, show axial length of the right eye within normal limits for the patient's age. The lens was not visualized on the axial scan. And the second image was obtained using the pseudo-immersion technique and did not show the lens in the anterior portions of the vitreous. In the longitudinal ultrasound scans of the right eye, we could see an image over the papillary area with an heterogeneous content best visualized in the inferior and temporal meridians from 7 to 9. It shows a well-defined hypoechogenic image associated with hyperreflected spots that persisted even after gain reduction and may correspond to calcifications. The punctate echoes are present in the vitreous cavity and may correspond to hemorrhagic process. Here are some videos. And at B-scan, it's possible to observe an atypical presentation of retinal detachment. The retina does not present any movement at the Kinect evaluation. We could also see vitreous and subretinal hemorrhages. Now I'll show with more details. In red, we can see the retina that is detached. In purple, we can see the dislocated lens. And here, in blue, we can see a suspicious area at a solid lesion with internal calcification located at the posterior pole with an acoustic shadow that is shown in orange. The punctate echoes are present in the vitreous cavity that may correspond to the vitreous hemorrhages and also subretinal hemorrhages. A brain and orbital MRI was performed, and in this axial scan, it's possible to observe the lens in the first image and the fluid level that's also visible in both images, corresponding to the presence of blood within the vitreous cavity. In the second image, there is a lesion with liposignal in T2. In the sagittal scan, the first image shows a T2 sequence, and we can see the lens, and over the lens, a hypointense lesion. The second image is a T1 with gadolinium, and we can see the lesion with enhancing after gadolinium. In the coronal scan, we can see the same thing. The first image in T2, we can see the lens, and over the lens, an hypointense lesion. In the second one, the T1 with gadolinium, we can see the enhancing of the lesion. In this image sequence, it's possible to observe that the lesion shows restricted diffusion. Even though the imaging exams could not differentiate whether the lesion was from a tumoral etiology or retinal detachment, we had the suspicion, along with the painful eye, non-seeing eye, and the other findings from the physical examination. So, an enucleation of the right eye was justified, and the material was sent for the histopathological analysis. Below are images of the histopathological slides. Those two images shows the retinoblastomas rosettes that are arrangements of tumor cells forming a circular structure around the central lumen. The first image is stained with hematoxylin and eosin. The pinkish areas represent the sclera, and among these pink fibers, clusters of small basophilic cells can be observed. Those are the tumor cells, and it's evident that the tumors has already deeply invaded the sclera. In the second image shows synaptophysin positive for tumoral cells. The brown stained areas representing the tumor cells invading and infiltrating the sclera. Those two images shows the retinoblastoma invading the optic nerve. The first one is stained with hematoxylin and eosin, and the second one with synaptophysin. Those images are both stained with hematoxylin and eosin. The first one shows the tumor invading the interior chamber, and the second one, the tumor invading the ciliary body. The histopathological report showed a moderately differentiated retinoblastoma involving the entire right eye. There was scleral infiltration and the circumferential margin was involved. There was choroidal infiltration greater than 3 millimeters. The optic nerve infiltration was present and was prelaminar, and the optic nerve margin was free of neoplasia. From the described characteristics, scleral infiltration with involving of the circumferential margin and a massive choroidal infiltration are risk factors for metastatic disease. As part of the conduct, we request exams for staging of the tumor. The whole body MRI and the cerebrospinal fluid show no abnormalities. The myelogram show presence of non-hematopoietic lineage cells, and the picture shows the infiltrations of the tumor cells in the bone marrow. The blue small cells are the retinoblastoma, and the other cells are the hematopoietic ones. We also performed a genetic test, and no pathogenic variants of the RB1 gene were identified. After the exams, we were able to classify this patient as a stage 4A in the international staging of extraocular disease, because the patient had distant metastasis, but not with the involvement of the central nervous system. In the TNM staging, the patient was T4, N1, M1A, H0, because he had a tumor that extended to the optic nerve with regional lymph node involvement, metastasis to the bone marrow, and no evidence of RB1 mutation. For the treatment, the patient underwent chemotherapy with the aerial 3-1 protocol, and also an autologous tendon bone marrow transplant. Doing the tendon transplant increased the treatment effectiveness. So I'll explain how it works. First, the patient undergoes an induction chemotherapy to negatify the tumor cells. Then the stem cells are collected only one time and are stored. The patient receives high-dose chemotherapies to destroy cancer cells, and afterwards, part of the stored stem cells are reinfused to the patients. After the recovery, the process is repeated. Another round of high-dose chemo, followed by another part of stem cell infusion. The patient of the case underwent this process 3 times and was successful. Nowadays, the patient is alive and has been off treatment for 2 years. 60 days after the last transplant, the patient underwent a liquid biopsy for minimal residual disease. Samples were collected from the right and left bone marrow, cerebrospinal fluid, and peripheral blood, and then were analyzed for 2 genes, CRX and RBP3, which are related to the photoreceptors and are present in the retinoblastoma. In these patients, there was no evidence of those genes in the testing. So, retinoblastoma can present with a variety of signs and symptoms. Dislocated lens is a very rare manifestation. There are only a few cases reported. The mechanism is believed to be necrosis of the zonular fibers and ciliary body caused by chemical mediators that are released by the tumors or by the direct infiltration of the tumor. In some cases, it also happens because of the lens, the tumor stretching the lens. So this presentation highlights that retinoblastoma can present with a variety of signs and symptoms, and atypical cases may be challenging to recognize. Retinoblastoma is a systemic disease that requires multidisciplinary management. And fortunately, new treatments modalities are improving survival rates, even in advanced stages of the disease. Thank you.
Okay. Thank you very much.
Thank
So
you.
let's see if Dr. Teixeira wants to add any comment. How long do you do the follow-up after these patients? every 4 months, maybe? I don't know. What's the... Because nowadays he's 2 years, Daniela, with no disease, right?
Yes, no disease, no treatment, just doing the follow-ups.
Okay, let's see how are the follow-ups.
Thank you. And congratulations, Daniela, for your excellent presentation. It
Thank
was
you.
very nice. This is a difficult case to present, and it's a case that has a lot of issues to discuss. When you have a extraocular disease, you need to have all the facilities to try to improve the treatment of this child. We could see that the child received an amount of chemotherapy with 3 autologous transplants. And this is not easy because sometimes we lose the child during the transplant by infection disease and also other complications. And also we have an increase of recurrence in this kind of staging. So we need to follow this child for a long period because sometimes we have late recurrence, even in the CSF. Even if in the start of the treatment it was negative for infiltration in the CNS, sometimes we during the follow-up we can see recurrence, and it's extremely difficult to treat this kind of recurrence. And also we can have a new tumor growing in other parts of this patient. So we need to follow close this patient with all the oncology pediatric group. And one thing that we are doing now is to try the liquid biopsy to analyze minimal residual disease. So what we do, we collect the fluids of the body. So we collect blood, CSF, and the bone marrow, and we analyze the RNA of these 2 genes. These 2 genes is only genes expressed in photoreceptors and in the tumor. So if you find these copies of this RNA in these fluids, it represents that you had some circulating cells of the tumor near these sites, because the tumor lose the DNA and RNA material when the cell is in apoptosis or is dying, and so you can analyze this material. So and this is a PCR, digital PCR, that is extremely sensible and specific for analyzing this material. So we follow these children with this, and we are learning with other groups, international groups, what it represents for the new treatments for these children. We don't know all the answers yet.
Would you consider at what age of a child that presented with retinoblastoma age 3 and no disease at age 5, at what age would you consider he's not at risk anymore? Like adolescence only or late?
After the treatment?
Yes.
After the treatment? Oh, it's a long period. We, even in the eye, sometimes we have late recurrence. We had 2 patients now, and we know from other groups that they have patients with long-term recurrence. For example, 10 years after, you can have bone marrow recurrence, and you don't see nothing during all these 10 years, and then grow a tumor in the bone, and you think that could be a sarcoma or osteosarcoma, and then when you do perform a biopsy, and you find the retinoblastoma that is still there for dormance for 10, 15 years. So we need to follow these patients for a long period. And even in the eye, we have a patient from Campinas, Boldrini, that we helped them, and they treated the patient with 3 years old. They finished the treatment in the eye, and the eye recurred after 17 years. So
Wow.
we need to follow these patients.
So the patient was almost adult.
Yeah,
That's
it's rare, but can occur.
different. Is UIC online? Okay. Can see Dr. McIntosh.
Hi, can you hear us?
Excellent.
Yes, we are here.
Do you guys have any questions?
This is Dr. Heiferman. He's
Hey.
our retina faculty. Jim
Mike
Cummins.
Heiferman. No, it's a great case. I don't treat retinoblastoma, but I find it very interesting. I'm curious about your liquid biopsy. Are you guys doing that in-house, or do you send it to Los Angeles? And do you ever get liquid biopsy on aqueous or vitreous or anything like that? Probably not vitreous, but at least aqueous.
So you are asking if we do it in the vitreous or aqueous? Yes?
No, I see for this case, you did a liquid biopsy on the CSF and the bone marrow. Some centers now are doing liquid biopsy on aqueous for the retinoblastoma cases. Certainly not for this case. It's a non-seeing eye. You're planning a nucleation. It seemed like you made all the right decisions. But I'm wondering if with your other cases, if you've been doing any liquid biopsies for some of these genes that you were looking at to monitor for response to therapy or for long-term recurrence.
Yes, we perform the liquid biopsy from aqueous humor for intraocular disease, but in this case it's an extraocular disease, so we use for other liquids like the blood and CSF, but we use for analyze the genes in the aqueous humor.
And then typically we'll get MRIs every 6 months until they reach the age of 5. But given the bone marrow involvement for this patient, do you know if they're recommending more MRIs longer term?
Yes, we perform the total body MRI and all the tests, the CSF tap and bone marrow tap and biopsy and the liquid biopsy for a period of follow-up. Yes.
Yeah, this is a tough case. It's a tough presentation. Nice job.
Thank you.
Okay. Thank you, Daniela, Dr. Teixeira. Let's move on. We have a second case. The presenter will be Rafael Feitosa, and the preceptor will be Dr. Mônica Rinquevicius. It's an emergency room session.
Good evening, everyone. My name is Rafael. I'm a second-year resident of the service, and today I'll be presenting the Grand Round of the Emergency Room Division, supervised by Dr. Mônica Rinquevicius. The head of the division is Dr. Luciana Noia. Our patient is a 42-year-old male, a bus driver from São Paulo, Brazil. He has a no history of type 2 diabetes. Currently, only had insulin therapy. He was hospitalized due to decompensated diabetes. During this period, he developed progressive pain in the erythema of the upper eyelid, associated with worsening visual acuity in the left eye. He denies any other relevant past medical or ocular history, allergies, or use of chronic medications. He also denies a family history of ocular disease. On ophthalmologic examination, the best corrected visual acuity was 20/40 in the right eye and no light perception in the left eye. Intraocular pressure was 12 millimeters of the mercury in the right eye and could not be measured in the left eye. On a slit lamp examination, the right eye showed clear conjunctiva, a transparent cornea, and a well-formed anterior chamber, with no cells or flare. The iris was trophic and the eye was phakic. In the left eye, eyelid opening was minimal, and there is marked disorganization of the ocular surface structures, with extreme tissue friability, preventing a detailed anterior segment evaluation. Extraocular motility was normal in the right eye, but with total restriction in the left eye. On fundoscopy examination, the right eye had a pink optic disc with sharp margins, a normal cup-to-disc ratio, normal macula and vessels, and the retina was attached. In the left eye, fundoscopy was not possible due to the condition of the anterior segment. So, for external examination,
Good evening, everyone. My name is Fernanda. I'm a first-year resident at this service. Here in the external examination, we can see the external aspect of both eyes. On the right eye, the eyelids and the eyelashes appears normal. The conjunctiva is clear, the cornea transparent, as said, and the iris appears trophic. On the left eye, there is a marked periorbital edema, which is indurated and extensive, associated with areas of necrosis and purulent discharge.
so for diagnostic hypothesis,
Good evening, everyone. My name is Christian Nogueira. I'm second-year resident here at the service. We have to think of orbital infections like bacterial or fungal cellulitis, non-infections, orbital inflammations as pseudotumor, sarcoidosis, vasculititis, and orbital tumors and infiltrations like lymphoma, metastasis, and lymphoproliferative disorders.
in fact, these were our initial hypotheses. So for diagnostic hypothesis, we had a 42-year-old patient with insulin-dependent diabetes mellitus and poor glycemic control. Ophthalmologic examination revealed edema and necrosis in both the eyelid and eyelash region. Among orbital infections, the main differentials would be bacterial cellulitis, which is far the most common, and fungal cellulitis, typically seen in immunocompromised patients such as diabetics. Regarding no infection orbital inflammations, we could think of idiopathic orbital inflammation, also known as pseudotumor, sarcoidosis, or vasculititis. These conditions can present with orbital swelling and pain, but usually lack the rapid necrosis and tissue destruction observed in this case. Finally, orbital tumors or infiltrative lesions, including lymphoma, metastasis, or other lymphoproliferative disorders, may occasionally simulate inflammatory presentations, although they tend to involve more insidiously. So, for the management,
Good evening, everyone. My name is Jose. I'm a third-year resident here at the service. So it's a patient with a very severe infection. So this patient should be admitted to the hospital, and we should first ask for an image of brain and orbit with a CT, also a blood workup, including cultures, if possible. Also, we should initiate broad spectrum antibiotics, and also ask for intermedicine or infectology evaluation, and also otolaryngology evaluation.
perfect, Jose. The magnetic resonance imaging revealed extensive left, pre, and post-septal cellulitis associated with myositis, neuritis, and dacroadenitis, with periorbital collection in organization. There was also evidence of pansinusopathy, with secretion inside the left maxillary sinus, suggesting a severe inflammatory or infectious process, in which an invasive fungal etiology should be considered. Additionally, we observed left pachymeningeal tightening and enhancement, compatible with inflammatory meningeal involvement, secondary to the orbital infection. On the right side, there is also mild osteomastoidopathy. Given the clinical severity and poor response to broad-spectrum antibiotics, an emergency nasal cavity biopsy was performed. The direct fungal examination was negative. Because of the aggressive progression and satisfactory response to antimicrobial therapy and evidence of central nervous system involvement, the surgical team decided to proceed with a left sinusotomy combined with an orbital exenteration. The procedure was carried out with support from the neurosurgery, rhinology, and head and neck surgery teams. Regarding infectious disease management, the patient was started on broad-spectrum antimicrobial therapy, including liposomal amphotericin B, isovuconazole, and linezolid, while waiting cutlery results for the surgical specimen. The combined approach aimed to control the infection locally and systemically, given the high mortality associated with rhino orbital cerebral mucormycosis, which at the moment was our main suspicion. This is the aspect of the left orbit after surgical intervention, showing extensive tissue loss and necrosis with residual inflammatory areas, The fungal examination of the biopsy specimen was positive for the presence of Mucormycete hyphae, confirming the diagnosis. The aerobic culture also grew Staphylococcus epidermidis and Staphylococcus omnis, both multisensory strains, representing secondary bacterial colonization of the surgical site. So, for discussion, rhino-orbital mucormycosis is a rare but extremely aggressive fungal infection that predominantly affects diabetic patients, especially those in ketoacidosis, and immunosuppressed individuals. A higher incidence was also observed during the COVID pandemic, likely related to the widespread use of corticosteroids and uncontrolled hyperglycemia. From a pathophysiological standpoint, Mucormycosis species exhibit angial invasion, leading to vascular thrombosis, tissue necrosis, and fulminant progression. The clinical presentation typically includes severe pain, hypoesthesia, ophthalmoplegia, and necrotic lesions of the eyelids, palate, or nasal mucosa. Importantly, the infection may sometimes progress without evidence bone destruction, spreading instead along perineural or vascular pathways. The diagnosis relies on a histopathologic confirmation, tox biopsy, and fungal culture, which demonstrated the characteristic broad, ribbon-like, non-septate hyphae. Imaging study, including computed tomography for paranasal sinus and orbital well evaluation, and contrast-enhanced magnetic resonance imaging for soft tissue, orbital apex, and central nervous system involvement, are crucial to determine the extent of the disease and to guide surgical planning. Early recognition and prompt intervention are essential in case of rhino-orbital cerebral mucormycosis, as management truly represents a race against time. According to the Code protocol, the first step is to classify the extent of the disease, beginning in the nasal or sinus region, then progressing to the orbit, and eventually to the central nervous system. A multidisciplinary approach is crucial, involving the teams of otolaryngology, ophthalmology, neurosurgery, and infectious disease, working together to plan both surgical and systemic management. Clinical stabilization includes strict control of hyperglycemia and ketoacidosis, and, whenever possible, discontinuation of predisposing factors such as corticosteroids or immunosuppressive drugs. Early and aggressive surgery is fundamental, consisting of wide sinonasal and orbital debridement, also guided by imaging, with frequent interventions when necessary to remove the vitalized tissue. Systemic antifungal therapy must be started immediately. The first-line treatment is a high-dose liposomal amphotericin B. This combined stepwise and multidisciplinary approach significantly increases the chance of survival and disease control in these otherwise devastating infections. So, thank you all.
Okay, is the patient alive?
Here's our teacher.
Okay. Congrats. Let's see Dr. Rinkevicius. She will probably have some notes. Monica?
Oh, hi.
Hi.
Dr. Hi, everybody. Was a very sad case that we got because it was a very young patients with diabetes, but the pronto diagnosticos made the treatment and the survival possible. There was not much things to do, but I made the hypothesis and initiate the treatment for the patient, but there's nothing else more that I need to say. Thank you.
I'd like to call, who wants to give any opinion on that case, like someone who does orbit or this kind of procedures, or even, I don't know if Dr. Luciana Noia is online.
Yes, yes, I'm here, and I'd like to congratulate the team for the management because it's not easy to indicate such a hard surgery, and but it's needed. It's extremely needed and very aggressive. But it's the only way to have any chance to save the life of the patient. Usually, this kind of intervention are made by the neck and head team or orbital team in a multidisciplinary approach. But it's crucial for the ophthalmologist not to take so long to think about mucormycosis, especially in diabetic patients.
Any comments, Luis?
No, congratulations for the case. This is a difficult case to handle, and sometimes you can ask for the nose surgery to see the mucosas of the sinus and the nose, and sometimes you are going to see necrosis areas, and then you can biopsy by nasal fibroscopy and try to do a quickly diagnose in the emergency room. Because this patient needs treatment quickly because it's so devastating, this condition, and sometimes even you have occlusion of the internal carotid and ischemia in the orbit or even in the brain. So it's a very difficult case to treat.
Manage. Rafael, I understood that you had performed rhino biopsy, right?
Yes, teacher, but the fungal
But it was negative,
was
right?
negative in this occasion.
Okay. From the team from UIC, would you like to make any
Yeah,
comment?
just to thank you. I do want to just point out that we're in our auditorium, so I apologize. You can't see all of the faces that are here, but we are all watching. This, of course, is a very challenging case, and congratulations for saving this patient's life. I guess my question is, what's the next step for rehabilitation, reconstruction for this patient's face?
So sometimes you can rotate the temporal muscle and feel the orbit and then make some reconstruction of the aspect of the lid, but it takes time to do. But you can use the temporal muscle and feel the orbit with the plastic surgery, general plastic surgery.
Does your team in oculoplastic perform this reconstruction, Dr. McIntosh, at UIC? Because I think
We have our oculoplastics fellow here. I'll let her comment on
Perfect.
reconstruction of these. Thank you. Thank you.
Hello. Hi, my name is Sasha. I'm the oculoplastics fellow here. First of all, wow, that was a really tough case, and it's amazing that the patient survived because usually once mucor gets into the intracranial space, it's, the mortality is so high. And like you said, being able to diagnose it very, very quickly and having ENT on board immediately to do serial sinus debridements is very important. In terms of reconstruction here, we also work with the general plastic surgery. We have a really good craniofacial plastic surgery department here, and so they would, for something like that, they would do a free flap most likely from from the forearm, either a radial or ulnar free flap, and anastomose the arteries that way. And so people who've had those have been doing really well.
Well, sorry for that. Ivan, it's Gilvan. Okay, thank you. Sorry for that.
Oh, no worries. And I had a question for you guys. Do you do retrobulbar amphotericin for patients with overall mucor? I mean, I see that in this case, it had already extended to the intracranial space, and it was kind of a heroic measure to exonerate. But I feel like sometimes I've heard people here say that if it's spread to the brain, then some people don't even want to do surgery because it's so morbid and the mortality rate is so high. So yeah, I was wondering what your decision-making process was for this patient particularly.
Would you know that Rafael or Dr. Rinkevicius, would you know if there was retrobulbar amphotericin? You don't know, right? If it was used, maybe it was not.
As far as I know, not in this case, and neither in the other cases we had recently. We had, I think, 3 cases last year, and they were so spread that we couldn't, we didn't think about making anything before going to surgery. Just rush for the surgery.
So no, in the 3 cases she could evaluate. Okay.
Yeah, they were very expensive.
Thank you. Great case. So let's see our friends from UIC.
Okay.
There are 2 case reports, and one will be presented by Dr. Lusky, Nina Lusky.
And she is here. Let's go.
Excellent. From our staff here, from Uveitis, we do have Dr. Cristina Mucioli logged in, Dr. Carlos Eduardo Souza, and Dr. Luciana Finamor.
Yes, fabulous. Oh, never mind. Display settings. Wow. Fabulous. Oh, but now I can't see. No, I can't see. Yeah.
Go back.
Yeah, I should. What'd you say? No, we don't want that. Okay. And then check this. Upper left. Yeah,
Then you can.
yeah.
But now swap it. Yeah.
No.
Great, we can see here. It's great.
How did I go back to this? Sorry, guys. One sec. Oh, hide that. Taskbar. There we go.
It's just what we did.
That's better.
And now it should.
How's it do it? I mean, I don't see mine, but that's okay.
That's it.
There it is.
Yeah, I don't see my notes, but we will go. Okay. Hi, everybody. I'm Nina Lesky. I'm one of the 3rd-year residents here at UIC, and I will be presenting my case titled Unmasking Vitritis. Let me put this away so you guys are able to see. Thanks to Dr. Hyperman for this interesting case. And, to keep your attention throughout this grand rounds and in honor of doing it with Unifesp, I've included some photos from my first trip to Brazil. So here's 10-year-old Nina with Christ the Redeemer, a classic photo in Rio. I have no financial disclosures. So this is the case of a 69-year-old female. She was referred to UIC in April 2024 for a chronic bilateral and asymmetric granulomatous panuveitis. Her symptoms, she described some spider webs and floaters in her eyes, both eyes for the past 2 years, some flashes in the right eye. She was already on difluprednate QID OU when she first presented to us. This was switched from Pred Forte due to worsening inflammation. No past ocular history. Her past medical history was significant for osteoporosis. She was taking calcium, vitamin D, and some unknown oral osteoporotic medication. Social history was unremarkable. Family history, she had no autoimmune conditions. And then uveitis review assistance was negative. At her first exam at UIC in April, her visual acuity at that time was 20/30 in both eyes. IOP was symmetric and normal. And then there was a 1+ APD noted in her right eye. Anterior segment exam demonstrated white and quiet conjunctiva and sclera. There was endopigment on her cornea. In the right eye, there was also 1+ AC cell. There was anterior lens capsule pigment as well as vitritis, the right eye worse than the left. On dilated fundus exam, she had a normal disc. There was some temporal atrophy of her macula, no vessel sheathing, and then she had these multifocal chorioretinal spot lesions in her periphery, 360 degrees, with some a little bit more confluent superiorly. The left eye was notable for, once again, normal appearing cup to disc and optic nerve. The macula had these large drusenoid changes, no sheathing, and then there was modeling, but no retinal lesions in the left eye and the periphery. This is an ultra-wide pseudocolor fundus photo of both eyes demonstrating these changes. The right eye, we kind of see the vitritis worse than the left, and then these lesions in the periphery. Here we see them inferiorly. The left eye, there are those macular drusenoid kind of changes, the yellowy lesions there. This is fundus autofluorescence. The right eye shows hypoautofluorescence in the areas of the chorioretinal lesions in the right eye. The left eye demonstrates these hyperautofluorescent kind of specks in the macula and along the vascular arcades. This is an OCT horizontal raster through the fovea. The right eye demonstrates diffuse retinal atrophy, loss of the outer retinal layers and the photoreceptors, though it spares the fovea. The left eye demonstrates these kind of drusen-like deposits in the subretinal space or sub-RPE space. On fluorescein angiography, early phase of the right eye, which is the transit eye, demonstrates hypofluorescence in the lesion at the area of the chorioretinal lesions. Later phase demonstrates hyperfluorescence of those same spots, as well as the nerve consistent. The nerve demonstrates leakage, and the spots are more consistent with staining. The left eye, early phase, there's modeled hypo and hyperautofluorescence, and then these areas of hyperfluorescence, these areas of hyperfluorescence become bigger in the macula and more intense, consistent with leakage, and we see the leakage of the disc once again. ICGA of the right eye shows hypofluorescence in the area of the chorioretinal lesions, and that's present in early and late stages or late phases. The left eye, pretty normal overall. So a little break from imaging. This is Nina's first surf experience in Maresias, Brazil. Beautiful place. So I want to open it up to the audience now. What would be on your differential diagnosis for a bilateral and asymmetric granulomatous panuveitis with multifocal choroiditis? You can just shout it out. So TB, sarcoid, syphilis, a classic, Catherine.
You want us to give?
MFC with panuveitis, good. VKH.
Is your team,
masquerade syndromes, yeah.
is your team answering? That's it? We cannot.
Yes, sorry, I'm kind of repeating as
Excellent, excellent. It's okay.
yeah. Anybody else?
Someone here in the chat is asking bee dump, leopard spots.
Okay, I like it. All right, well, I'll jump into it. So we can broadly classify non-infectious uveitis. So we can consider sarcoidosis, good job, Catherine, multifocal choroiditis with panuveitis. It could be birdshot, VKH, Behçet's, sympathetic ophthalmia, or possibly medication related. She's maybe taking a bisphosphonate, although typically more of an anterior segment inflammation. Could be an infectious uveitis, such as TB, syphilis, or toxo. And then, of course, you've got to consider masquerade syndromes like primary intraocular lymphoma. So with that differential in mind, we order the following workup with some basic labs, some targeted autoimmune labs, and then HLA-A29 for birdshot, some infectious labs, as well as an MRI brain in orbit to evaluate for lymphoma. Her results were remarkable for a rheumatoid factor that was slightly elevated. She didn't really have other symptoms consistent with rheumatoid arthritis otherwise. Toxo IgG was elevated, but IgM was notably normal. And then she did have a positive quant gold. At this time, we referred her to our colleagues in infectious diseases in May of 2025. They started her on RIPE therapy for possible ocular TB, and then shortly after initiation of therapy, she had a worsening of the vitritis and a drop in her visual acuity. So she was officially referred to the retina service at this time for a diagnostic vitrectomy for concern for masquerade versus ocular TB. So upon our first visit with Dr. Heiferman, he ordered a few additional workups. So she got a full body PET, didn't show any significant uptake. And then she had a lumbar puncture as well, which apart from a mildly elevated protein was largely normal. So at this point, it was decided that she should undergo diagnostic vitrectomy, which was performed in July of 2024. The specimen was hypocellular, so they weren't able to run cytology or flow cytometry on it. But it was notable for an elevated IL-10, IL-6 with an IL-10 to 6 ratio of 51, and then was positive for the MYD88 mutation, consistent with a primary vitreoretinal lymphoma. So to just classify lymphoma or intraocular lymphomas, there's kind of three main buckets that you want to consider. First is primary versus secondary nature of the disease. Primary is going to originate in the eye versus secondary originates outside the eye and then metastasizes to the eye. You also have to consider the anatomical location. So there's going to be adnexal, which is structure surrounding the eye, versus intraocular, which can then further be subdivided into vitreoretinal, which includes the retina, the vitreous, or the optic nerve, basically above Brooks membrane, or uveal, which includes the choroid, ciliary body, and or the iris. Lastly is the histology. So this will bring us back to medical school. You've got the two broader categories of Hodgkin's lymphoma and non-Hodgkin's lymphoma. Non-Hodgkin's is more common in the eye. Within that, there's the B-cell non-Hodgkin's lymphomas and the T-cells. Once again, B-cell is going to be the more common presentation in the eye. And then within B-cell, there's a number that we've learned about: diffuse large B-cell, follicular, extranodal, marginal. So why is this important? Basically, when we have a sense of if the tumor is primary and where it appears in the eye, this actually gives us good information of what we might be expecting on histology. For example, with primary vitreoretinal lymphomas, they tend to be diffuse large B-cell lymphomas in the vast majority of cases, which we know to be more aggressive with a poorer prognosis. This is in contrast to primary uveal or adnexal, which typically are lower grade small B-cell lymphomas and tend to confer a better prognosis. So in our case, it was primary intraocular, and specifically in the vitreous and the retina, and then was a B-cell lymphoma. So that's where we get our diagnosis. Some background, primary vitreoretinal lymphoma is considered a subtype of primary CNS lymphoma. The majority are high-grade diffuse large B-cell lymphomas, over 80%. And the diagnosis is often delayed 6 to 40 months on average. As you've seen in our case, for example, she was, and this is common, is people are misdiagnosed as having a uveitis. They're treated with steroids. They actually have a partial response, which is reassuring, but then, something clues you in that this is not responding fully, or there's other changes that are not totally consistent with a non-infectious uveitis. And then at presentation, about 1/3 of patients with a primary intraocular lymphoma also have CNS disease. If they don't have CNS disease, about 50 to 90% of patients go on to develop CNS disease at a later date. And as we briefly discussed, the prognosis is overall pretty poor at this time. 5-year survival rate has been reported to be about 25 to 40%. This largely is a disease of older adults, average age of 70 years old. There's no sex or racial predilection. And then even though, historically this has been associated with Epstein-Barr virus, HIV, we're getting better at treating that. But regardless, the incidence is still rising, most likely because people are living longer and we have better diagnostic tools. And this is a very rare disease. It accounts for about 0.1% of all intraocular tumors. Typically, this presents as a masquerade syndrome of uveitis or on eye screening following a diagnosis of primary CNS lymphoma. Patients describe blurry vision, decreased vision, or floaters. And it's typically on presentation bilateral in about 2/3 of cases, though it's often asymmetric. The common symptoms include vitritis and these subretinal, or signs of vitritis in these intrasubretinal cream-colored multifocal infiltrates. Less commonly, you can see a significant AC reaction, chorotic precipitates, panuveitis, optic nerve infiltration, exudative RD. And then very rarely it's associated with CME or and redness. And those are kind of key differentiators that might clue you in that this is not your typical uveitis. Imaging findings, fluorescein angiography can show these areas of hyper and hypofluorescence, and it's nicknamed kind of like a leopard retinopathy. OCT macula demonstrates these intraretinal or subretinal or sub-RPE deposits. And then autofluorescence also, or fundus autofluorescence also has this mixed kind of hypo and hyper autofluorescent appearance. Diagnosis, the gold standard is with a vitrectomy with cytology, but this is limited as we found out with our patient. For example, the cells in the sample are very scarce and fragile. So even if you do the best vitrectomy, you get the sample to the lab within 2 hours, you still might not have enough cells to run those tests. So we have some supplemental tests, immunohistochemistry, flow cytometry, also kind of rely on having a cellular sample. But then there's PCR analysis of immunoglobulin gene rearrangements. There's also the IL-10 and 6 ratio greater than 1. And then a newer kind of mutation is the MYD88 mutation. To go into the IL-10 to 6 ratio a little bit more, so IL-10 is a growth and differentiation factor for malignant B cells. It activates an inflammatory pathway different. We'll talk about that in a second, but it's a differentiation factor for the malignant B lymphocytes, while IL-6 tends to be elevated in inflammatory states. It can be sampled from the aqueous or with vitreous biopsy or sample. And it's not diagnostic, but it's a good screening tool with a high sensitivity reported to be about 88% and specificity of 85% when taken from the vitreous. However, you do have to be aware that there are false positives. This IL-10 can be elevated in toxo or ARN. So going into the MYD88 mutation, more work has been being done in this. So it's a protein that's associated with the innate immune system. It activates this pro-inflammatory pathway if mutated. And it's been commonly found in, reported in diffuse large B-cell lymphomas, especially those from immunoprivileged sites. And so newer studies have been looking at seeing if this can also be a marker of primary vitreoretinal lymphoma. And in the 3 studies that I reviewed, the sensitivity was about 67 to 75%. Patients who had confirmed primary vitreoretinal lymphoma were positive for this mutation. So it can serve as another marker in making this really challenging diagnosis, and I know we found it useful. So once diagnosis of primary vitreoretinal lymphoma has been made, it's crucial to pick a complete systemic workup for staging, which includes an MRI brain and orbit with and without, lumbar puncture, both of those to assess for CNS involvement, as well as a full body PET or CT, and testicular ultrasound to assess for primary lymphoma, systemic lymphoma. A little break, a lot of information. This is Nina in Bahia. The very cute costume there. I'll be wearing that when I come see you guys in Brazil in April. So treatment approaches. Treatment of the primary CNS lymphoma is a little bit more accepted. There's better evidence to support best treatment. So first off, we have the induction phase, typically done with high-dose methotrexate alone. Newer studies show some benefit of doing it in combination with some other agents, although higher reported side effects as you'd expect. Followed by once you're in remission, to improve the progression-free survival, patients undergo whole brain radiotherapy, high dose chemotherapy, autologous stem cell transplantation, or non-myeloablative chemotherapy. And then lastly, there's more work being done to look at if there's a role for maintenance therapy, especially in those who are maybe unable to tolerate some of those consolidation therapies as well. When it comes to treatment of primary vitreoretinal lymphoma, we have some other options. So there's a systemic control side, which is the goal is to decrease potential CNS dissemination. And some people also use it to try to treat the ocular disease itself. But then there's a number of local control methods, including intravitreal methotrexate injections, intravitreal rituximab, and then external beam radiotherapy. And their respective side effects are listed here. But overall, unlike treating primary CNS lymphoma, treating primary vitreoretinal lymphoma presents a lot more difficulty. There's not really a consensus at the best treatment approach, mainly because it's a rare disease and we lack good randomized clinical trials. We mostly rely on retrospective data and case series to guide our current treatment regimen. So treatment of ocular lymphoma and CNS involvement, as we said, that's about 33% of cases. It's pretty accepted that you do both systemic chemotherapy and local ocular treatment. That's the majority of how people practice. But when it's ocular involvement only, this is kind of when it becomes a little bit more an adventure. There's kind of three broad treatment approaches. The first one is doing local therapy only, so doing injections versus external beam radiotherapy. The second would be doing just systemic chemotherapy only. Though levels of methotrexate are lower, they do reach on studies have shown that they do actually penetrate the eye and can treat the disease. And then lastly, there's a combination of local and systemic therapy. So even though there's no systemic disease at this time, the goal is to not only treat the eye, but also with such a high rate of progression to CNS involvement to hopefully decrease that dissemination with early treatment. However, a review article that looked at 30 studies of primary vitreoretinal lymphoma that met inclusion criteria. They compared the outcomes of these three treatment approaches with the primary outcomes of local control, CNS progression, and then overall survival. And then when they compared the median time to CNS progression, all three were pretty comparable. So even with treating with systemic therapy, it didn't show in this, review to delay CNS progression. The overall survival was similar in the local and systemic only treatment groups and initially seemed promising in the combo therapy, but when adjusted for lead time bias, the median overall survival was comparable across all groups. So to go back to our patient briefly, she was diagnosed in April. She came in April, diagnosed in July. She started on, we did local treatment with external beam radiotherapy, which was selected because she had bilateral ocular involvement. In November of 2024, on routine, on screening MRI, she did have new CNS involvement. Which we see here in the temporal lobe, and then there was also a cerebellar lesion. And so the decision was made to start her on systemic chemotherapy in conjunction with our oncologists in December. She went into complete remission from a CNS disease standpoint in February, finished chemo in March, and then underwent consolidation therapy in May with high-dose chemotherapy and autologous limbal stem cell transplant, not limbal. In July, she ended up having an ocular relapse in the left eye. There was worsening vitritis as well as recurrence of disc leakage on FA. And so the decision was made to start her on local treatment with intravitreal methotrexate in the left eye only, Moorfield's protocol, which treats relapsed ocular lymphoma. She's getting monitored with Q3-month MRI brains at this time without reoccurrence. So last visit, about 2 weeks ago, vision was down slightly from that initial visit. She's 20/50 in the right, 20/80 in the left. She's undergoing treatment only in her left eye at this time, getting Q2-week injections for the next 4 months and then space out further. No CNS disease recurrence, but being monitored closely. And then we also have had, from an adverse effects profile, she is experiencing dry eye with limbal stem cell deficiency, likely related to the history of radiotherapy. So overall, should we treat local primary vitreoretinal lymphoma with combination therapy? Good question. In theory, systemic chemotherapy treats the subclinical disease, but there's kind of a lack of randomized control trials at this time or prospective data to guide us. Individual studies are based on small cohorts, have conflicting outcomes, and literature review suggests that there's no CNS progression or survival benefit despite treatment with combo therapy. So the side effect profile of systemic chemotherapy is also worse. So that's something you have to consider, especially in our elderly population. And so it's my opinion that, it's reasonable to treat local disease with local therapy, but there's definitely a need for high quality clinical trials to assess the role of adjuvant systemic chemotherapy in the future. Here are my resources, and I just want to thank you guys for listening, and some photos from when Daniela was here. We would like to open it up to any questions and comments on how you guys go about treating primary vitreoretinal lymphoma in Brazil. With ocular involvement only, I'd be curious.
Okay, great case. Very well documented. Let's see if Dr. Heiferman wants to make a comment before our team here.
Great job, Dr. Lusky. Way to present a complicated case so clearly. Yeah, I find intraocular lymphoma very interesting, partially because the practice patterns are so variable, which really explained very clearly. Certainly the diagnosis can be challenging, as it was in this case. I think this case was particularly interesting to me because she converted to CNS involvement so quickly after we treated the primary disease. Ever since I started practicing, I've always pushed our oncologists to start treating the systemic disease, even when there's just local involvement, simply because the conversion rate is reported to be as high as 90%. I mean, functionally, it really is the same disease as CNS lymphoma. Some people are even calling it the same disease. Some people call it primary CNS lymphoma ocular variant for that reason. So to me, it's an easy decision. The oncologists see it from the other side. The systemic chemotherapy certainly come with risk. Some of these patients are older and can't tolerate those risks. But to me, it's better than the theoretical conversion to CNS involvement. And so now most of them will treat systemically with local only. And this is one of the patients that actually helped convince them. So I thought it was particularly demonstrative of that topic, and she summarized it well.
I cannot remember her age, this patient's age at the beginning.
69.
69, right. Let's see if Dr. Carlos Eduardo Souza is online, or Cristina Mucioli. I would like to have their inputs here. Dr. Luis Teixeira again.
Yes. I just want to make a quick comment. First of all, congratulations for this so difficult diagnosis. Although it's a rare disease, you presented it very well, and including the lecture, it's a very good presentation with a very good explanation and review. Thanks. And for the ones that are beginning, like new year of residence or fellowship, and it's very important to see that how difficult this diagnosis is. It's so easy when you have this so well explained and so well documented. But I just want to make one note for each sign that makes no sense for whatever diagnosis that you're thinking about. Like, oh, how she said at the beginning, oh, is this tuberculosis, sarcoidosis? Oh, looks like, okay, let's treat the patient for it. No, there are many signs that we can't pose the diagnosis. We can't say, no, it is. But every time when you see something that makes no sense with your diagnosis, please go back to the beginning, start all over again. Then you will get the right diagnosis. And also, I want to take your attention on how long does it take to the confirmation of the diagnosis and what was involved, like exams, clinical exams, lumbar puncture, and vitrectomy, and a good pathology. So that's very important. So there are many, we have no much time for it, but it's a very, I just want to finish congratulating you. It's a wonderful presentation, very nice case, very hard to diagnose and to treat. Congratulations. And for the ones that are just starting on UVI, please pay attention on whatever makes no sense for your first diagnosis. Thank you.
Yeah, I totally agree. I always emphasize with the residents the importance of a very complete differential, because when something isn't behaving the way you think it is, then you really need to go back and look at that again. So very well put.
Is Dr. Cadu here with us? Dr. Camila Campelo was also mentioned. Cadu?
Sorry.
Camila?
Good night, everyone.
Hello.
Hello, good evening. Sorry, it's dark because I'm in the car. Sorry. It was a very nice presentation, well presented. I just would highlight that here in Brazil, we always think about infectious disease first. So when I saw the first OCT image, I thought about syphilis for sure, that serrated pattern. But when you see the other images and when you start to think about the age and the response to treatment, so I think we have to consider the differential diagnosis. But here in Brazil, we always have to think first of infectious disease for sure. But amazing case, really amazing.
Thank you. Dr. Teixeira, do you want to make a comment?
Only congratulate the team, because it's a difficult case to make diagnose and even to treat, and ask a question for Dr. Greg. Do you use the MID88 analysis for follow-up of the eye? If you are using the gene analysis for seeing early recurrence?
Yeah, I know some people are doing it to look for treatment response and to monitor for early recurrence in the aqueous. I've taken some aqueous specimens, particularly when I'm doing at the time of vitrectomy. I think the sensitivity is probably lower compared to the vitreous specimen due to the location of the disease. You know, I do wonder if there's value to that. On the other hand, putting them through the aqueous tap periodically at the follow-up might be difficult. But on the other hand, sometimes we're giving them methotrexate and Rituxan and have to do an aqueous tap. Either way, I think sending those specimens to the lab is very reasonable. And for some of those patients where they've had local recurrence more than once and I'm doing multiple drugs in the vitreous, I'll send those aqueous specimens to the lab for PCR over time.
Only one more question. Do you prefer methotrexate than rituximab for the injection in the eye?
Yeah, I mean, there's no strong evidence to support one decision over the other. I personally do methotrexate first line. If they fail that, I'll go to Rituxan. Not usually second line, though. If they fail methotrexate first line in a unilateral disease without systemic involvement, then I'll go to external beam radiation as my second line. And if they fail that, then I'll go to Rituxan, either Rituxan alone or methotrexate and Rituxan, depending on the case.
Okay, thank you.
Excellent. Thank you so much. We should move on to the next case. So I know your presenter will be Dr. Gregory Tsugranis.
All right. Well, thanks very much for the opportunity to present today. My name is Greg Tsugranis. I'm one of the PGY3 residents here at UIC. I also want to thank Dr. Heiferman for the very interesting case, and also thank all of our colleagues in Brazil Thanks very much for joining today. I look forward to working with you when I come to Brazil in April with Nina. I have no financial disclosures. So our patient today is a 44-year-old female presenting to Dr. Heiferman's retina clinic with a 3-month history of a single floater and shadow in her central vision of the right eye that evolved into a shower of floaters over the last week. Notably, the patient did not endorse photopsias or curtain sensation. She had previously been seen in our resident-run general eye clinic and was diagnosed with a hemorrhagic posterior vitreous detachment. However, no holes, tears, or detachments had been identified on serial scleral depressed examination of her retina. She had no past ocular surgery. Other pertinent negatives for her included no history of blood thinner use, no past ocular trauma, no heavy lifting or straining, and no history of diabetes, and she was a half pack per day smoker. Her vision was 20/20 in both eyes. Her intraocular pressures were normal. There was no APD, and her confrontation visual fields were full. Her anterior segment exam overall was unremarkable. Notably, there was no vitreous cell noted at this time. So here is the optos of the right eye. Would any residents be willing to discuss what they see here?
Can you translate? Or
Yes, actually, we're handing out a microphone right now, so you should.
Hi, I'm Cassie, one of the PGY3 ophthalmology residents here. This is a pseudo-color wide field fundus photo of the right eye. When looking at the media, there's an area of vitreous haze or condensation that overlies the optic nerve and extends nasally with obscuration of the underlying retina. Otherwise, the vitreous does appear clear aside from that area. The nerve cannot really be visualized. The vessels are normal in coursing caliber. The macula appears flat and attached, and the periphery is unremarkable.
Great, awesome, Cassie. Thanks for that. So let's see here. And then also I've included the left eye here. Just for time's sake, this is a grossly normal optopseudocolor fundus photo of the left eye without any vitreous condensation in that left eye. And here's a quick summary of the findings. Some additional findings that were not seen on the optos that were seen on scleral depressed exam, notably in the right eye. There was also this area of retinoschisis at 8 o'clock, but no holes, tears, or detachments again on scleral depression. And then there was some inferotemporal lattice noted in the left eye. I've also included the fluorescein angiogram here of the right eye. Unfortunately, we don't have time frames, but basically the image on the left is an earlier time frame. Would any of the residents be willing to read what they see here?
cannot listen.
Yeah. So basically what we see here is this area of hypofluorescence basically consistent with blocking. So that corresponds to that area of vitreous condensation. Here's the left eye. That's grossly unremarkable. So the patient returned 3 months later with subjective worsening of the blurriness in that right eye with increased floaters. Her visual acuity had decreased to 20/25 from 20/20. And now on anterior segment exam, notably there was 3+ anterior vitreous that right eye. And the dilated fundus exam was similar to prior. Here I've included the patient's OCT macula of the right eye from that visit. Basically noted here is that in the media, there is this small area of debris or opacification. Otherwise, the retinal layers are preserved. And you will notice here that there is more prominent disruption of, more prominent medial opacification nasally, where there is disruption of the OCT signal. And then the OCT of the left eye was grossly unremarkable. So in summary, we have a 44-year-old female initially presented with a shower of floaters in the right eye in the setting of vitreous cell, a dense vitreous opacification, no holes, tears, or detachments noted on scleral depressed exam, however, and no signs of leakage on fluorescein angiography. Would anybody be willing to kind of shout out some pathologies on the differential diagnosis? Yep, great. TB, sarcoid syphilis. Anything else? Endophthalmitis, MS, the neoplastic process is some sort of like intermediate uveitis. Anything else? Pars planitis. Great. So many of these things have kind of already been outlined. So an intermediate uveitis, whether infectious or non-infectious or idiopathic, we must also consider neoplasm in someone with a rapidly worsening vitreous cell unilaterally as well, leukemia or metastasis. Endophthalmitis is also a possibility, however, a bit less likely in a patient who has a negative surgical history, no systemic symptoms, and it's not immunocompromised. Asteroid is also a consideration, however, likely wouldn't become visually significant over a short time frame. Chronic vitreous hemorrhage is also possible, however, less likely without a history of diabetes. Oh, and then thanks. And then also, we can also consider syncytial scintillans. This is like a rare degenerative ocular condition characterized by cholesterol crystals. However, this typically would appear more like crystalline structures. Like I mentioned, it is more gravity dependent. And then we can also consider ocular amyloidosis. So with the new onset vitreous cell, the initial diagnosis, of course, of hemorrhagic PVD became much less likely. And a diagnostic workup was pursued to include all of the lab tests and the chest x-ray included here, all of which came back within normal limits. At that time, we recommended possible uveitis evaluation versus a diagnostic pars plana vitrectomy in the right eye. However, the patient was lost to follow-up for about 7 months after this. And when she returned 7 months later, noticed worsening of the blurry vision, was now count fingers at 1 foot in that right eye. With the worsening anterior vitreous cell. And now on the dilated fundus exam, there was a much hazier view with increased density of the vitreous condensation extending over that optic nerve, which I've included in an image here. So basically, that same vitreous condensation is now enlarged. It's much more difficult to visualize the nerve, the macula, and the nasal retina here. And then just to kind of prove a point even further, the OCT is very unclear due to the medial opacification. So at that time, malignancy was included in the differential diagnosis, so a systemic workup was pursued. An MRI of the brain and orbits was largely unremarkable. A full body PET with CT was also unremarkable. And then the diagnostic pars plana vitrectomy was done with core vitrectomy. Intraoperative examination showed vitreous debris with tufts of adhesions between the retina and the posterior hyaloid. And then once again, no evidence of retinal holes, tears, or detachments. However, there was this vitreoretinal tuft supratemporally in the right eye that was laser barricaded. Here I've included some of the lab tests from the diagnostic pars plana vitrectomy, notably the infectious workup here was all unremarkable. I've also included the fungal 28S rDNA and the 16S rRNA. Those are basically markers for fungi and bacteria, respectively. I won't delve into too many details since Nina kind of already discussed the interleukin 6 and interleukin 10, as well as the MYD88. But basically, this patient's IL-6 and IL-10 levels were well below the level of quantitation and therefore immeasurable. So we couldn't really even create an IL-10 to IL-6 ratio. But the fact that these levels were so low likely pointed to the fact that this was not an inflammatory condition. And then just to quickly summarize what Nina kind of mentioned regarding the ratio itself. So next on to the vitreous sample pathology. So this is a pap stain cytospin. The blue material included is amorphous proteinaceous material. Notably, the most important finding is that this slide is acellular, thus making lymphoma, endophthalmitis, some sort of autoimmune process much less likely due to the lack of an inflammatory response. Next, I've included the patient's cell block with the notable stain color. Would any of the residents be willing to share what stain they might see here based on the color that you see? Congo red, great. Yeah, so this is a Congo red stain. And then when you, positive congruent, excuse me, and then when you shine polarized light at it, you have this pathognomonic finding. Anyone willing to share what they? Yep, so it's apple green birefringence. And the basically clinches the diagnosis of amyloidosis. Therefore, the final diagnosis was amyloid, but Dr. Heiferman wanted to pursue even further testing to identify this specific amyloid protein subtype. And in this case, it was the ATTR, the transthyretin subtype. So a bit about amyloidosis. It's a diverse, heterogeneous group of disorders characterized by the deposition of hyaline into a variety of tissues throughout the body, including the eye and the ocular adnexa. The amyloid proteins themselves are deposited as insoluble fibrils as a consequence of abnormal protein folding. And then histology is generally required for a definitive diagnosis, which is often made with a positive Congo red staining, like I mentioned, or the apple green birefringence under polarized light. Apart from the ocular manifestations, all patients do require systemic workup regardless of the subtype of amyloidosis because there are possible fatal complications. This is typically driven by the patient's primary care doctor, but typically we prefer cardiac workup, including echocardiography, to look for cardiomyopathy. Also a renal workup, including urinalysis, to look for nephrotic syndrome or signs of kidney injury or renal failure. And then some primary care doctors will also pursue hepatic workup to look for any signs of liver damage. Based on the amyloid protein that is identified, clinicians refer to the disease as a specific subtype, including systemic AL, which is amyloid light chain, AA, amyloid A protein, or ATTR, which is the transthyretin subtype. And these subtypes are often further characterized with whether they're systemic, localized, wild type, or mutant. So ocular amyloidosis is most frequently attributed to localized amyloid light chain amyloidosis, accounting for almost 80% of the cases, followed by systemic AL amyloidosis. Together, these subtypes now account for about like 95% of all cases of ocular amyloidosis. Ocular manifestations in AL amyloidosis are mostly extraocular, involving the orbit, conjunctiva, even the temporal artery, and even the extraocular muscles. Regarding vitreous involvement, so more pertinent to our patient, this occurs most frequently in the ATTR or transthyretin amyloidosis. And in approximately 10% of cases of people who have transthyretin amyloidosis will have vitreous involvement, with the retina itself only being affected very rarely. So just a bit more about orbital amyloidosis, since this is much more common than the vitreous manifestations. Some of the most common pathologies include nodular infiltration of the extraocular muscles in the orbital adnexa, which can lead to proptosis or ophthalmoplegia that can sometimes mimic thyroid orbitopathy. The optic nerve can also be involved if the infiltrates invade the orbital apex, leading to an orbital apex syndrome, or even the optic nerve dura, which can lead to a compressive optic neuropathy. Other presentations include infiltration of amyloid into the lacrimal gland, leading to a lacrimal gland mass. And then there are even case reports showing that AL or amyloid light chain amyloidosis may present a clinical picture similar to temporal arteritis due to amyloid light chain infiltration of the temporal artery. Conjunctival amyloidosis can affect healthy people of any age or gender and can cause nodular or diffuse deposits on the bulbar or tarsal conjunctiva. And I've included an image of that here on your left, showing the classic yellow or waxy appearance of the conjunctival amyloidosis, while the image on the right shows infiltration of the patient's right lateral rectus. Amyloidosis also has implications on corneal pathology, can occur as a localized or systemic disease. Primary localized corneal amyloidosis has two distinct inherited forms, which is gelatinous drop-like dystrophy, which is a rare corneal condition characterized by amyloid deposition cell epithelially in the stroma. And then also lattice corneal dystrophy types 1 and 3. In terms of systemic manifestations, Meritoya syndrome is the main form of primary systemic amyloidosis that presents with lateral corneal dystrophy type 2 and can include progressive bilateral cranial neuropathies with facial palsies, peripheral neuropathies, walking difficulties, and the characteristic mask-like faces included on the slide here. And then again, most pertinent to our patient presentation is vitreous amyloidosis. As I mentioned earlier, it's the most commonly seen in the ATTR transthyretin mutant amyloidosis. And in regards to the pathogenesis, the RPE actually manufactures transthyretin itself and can also manufacture the mutant type and release it into the vitreous. The other main source that causes systemic transthyretin amyloidosis is the liver, and many of these patients who have systemic manifestations often undergo liver transplantation. In individuals with FAP or familial amyloidosis polyneuropathy, which is a condition caused by transthyretin deposition into the peripheral nerves that causes ascending neuropathy and can be fatal, these patients have up to 35% incidence of vitreous amyloidosis. And in general, these vitreous opacities are usually bilateral, can be asymmetric, can lead to cobweb sheets or crystalline needle structures in the vitreous, and symptoms can range from mild glare to severe visual impairment. And that spectrum was actually seen in our patient. And then just quickly to summarize a bit more about this transthyretin mutant amyloidosis, as I mentioned, this transthyretin is manufactured by the RPE, which is why the vitreous is involved. In these individuals who have confirmed transthyretin amyloidosis, it's important to evaluate for concurrent glaucoma, where studies have shown about 5 to 28% of these patients have an open-angle glaucoma, and this is thought to be due to amyloid deposition in the trabecular meshwork. With regards to treatment, these patients most of the time need to undergo pars plana vitrectomy if the amyloid deposits are visually significant. And it's very, very important when these patients undergo vitrectomy to undergo scleral depression as well to make sure that there is complete vitrectomy, removal of all of the vitreous. One study from Portugal actually found that incomplete vitrectomy was the highest risk factor for recurrence. So the importance of vitrectomy is emphasized here. So back to our patient, they were most recently seen in Dr. Heiferman's clinic back in May, and the vision is 20/20 in the right eye now. No vitreous cell now after their vitrectomy. There's no cardiac, renal, hepatic, or neuronal involvement. They're being monitored by our retina department every 6 months and are following with glaucoma with serial intraocular pressure checks that have all been normal so far without any signs of glaucoma. Here are my references, and thank you very much for your attention. Here's the CME code as well for those who need it. I'd be happy to take any questions or comments.
Okay, so about the left eye was never involved
Nope, the left eye was never involved.
yet. Very good. Dr. Heiferman, do you want to comment on that case? It's another very well documented and severe case.
Yeah, great job, Dr. Sugranis. Yeah, amyloid is very interesting. The high rate of glaucoma after post-vitrectomized amyloid eyes is like 70%. So being sure to get the appropriate referrals, primary care. I insist they see a cardiologist, and then seeing glaucoma, longitudinally is very important. So I think it was an interesting case and some great pathology slides.
Yeah. Would you like to make any comment, Cristina Mucioli, Luis Teixeira, or anyone from our team here? Iago is in the retina session.
Another complicated, rare case, very well documented. Actually, I saw a few cases in my entire life, most of them with cardiac involvement. And I have a question, like the patient was completely asymptomatic. I'm questioning systemically, no signs, no previous amyloidosis, and then the diagnosis was made by ocular involvement. Is that right?
Yeah, that's right. She was otherwise a healthy woman.
Oh, wonderful. It's more, I think it's more rare, more difficult when we have this. I followed some patients with clinical diagnosis of amyloidosis, and I followed them to check how or if they will develop some eye involvement. So I'm following one case that had ocular involvement and previous to the systemic, but all the others I've followed, they presented with a systemic and sometimes they develop some eye involvement. So no, but again, it's a very rare, it's not a common diagnosis, but we have to have all the rare diagnoses in mind as well. So congratulations. I appreciated your cases and especially the important review that you gave to us. Thank you.
All right, very good. All right, maybe I'll answer some of these. There's a question in the
Audience?
comments here. Yeah, I'll read it out loud. I'd like to emphasize the importance of building our diagnostic reasoning based on local epidemiology. In developing countries like ours, it's essential to escalate testing step by step, considering not only cost effectiveness, but also our local disease patterns. And of course, keeping in mind the red flags that help us distinguish inflammatory from neoplastic metabolic causes. Congratulations. Yeah, it's true. And I'm a retina trained ocular oncologist, so I primarily get these referred after many of the infectious and inflammatory etiologies have been ruled out. So a lot of that hard work is done by our uveitis colleagues, but certainly you wouldn't order all these testings, initially, right? You wouldn't get an MRI of the brain and a full body PET CT and a lumbar puncture on every single one of your patients with vitreous cells. So I think that's a very well-made point.
Okay, because our audience knows we are always on time. I'd like to thank all UIC staff, Dr. McIntosh, Dr. Chan. I know you.
Thanks, Norma. Sorry I was late. I was
No,
talking to
you're not
Paula
late.
Dantas. So it's good to see you.
Good
And
to see
thanks
you.
to all of you for doing this with us.
No, I really think it's challenging, right? For your team and also for ours. But I think we always learn. Staff, residents, audience, we all learn with the cases and each other presentations. So Dr. Tavares, any comments? Just say hello and thank you to all the team, right?
Yeah, that's it, Norma, and congratulate the UIC and our team, of course, for one more joint rounds with both institutions. Thank you.
Thank you very much for the effort. I know it's a challenge, but it was great to have you here.
No, thank you, Norma. Thanks, everyone.
So,
till next time.
Till next time, next year. Thank you very much.
We'll see you soon.
See you soon at the American Academy.
Thank you.
Bye.